patient is performing. Okay, here we just adjusted by a conversion rate of 0.75, leading to 8.26 centimeters of water, which indicates that that effort is appropriate. The safety range of the muscle effort is no more than 13, so we can objectivize in a simple and swift manner how the inspiration effort is going. With ultrasound, of course, we can guide this. It is a measure that is already available in most units and is not invasive. In this case, what I showed right now is the evaluation of the diaphragmatic cuffs through a sector device, which is precisely subcostal, and we're going to try to ultrasound this section, the diaphragmatic cuff, and then we're going to evaluate how the excursion of the diaphragm occurs. Here we have normal excursion, 2.8 centimeters, which indicates a proper inspiration effort by the patient with regular efforts, and we can see the fraction of shortening with a linear transducer to the diaphragm apposition area, identifying in inspiration and expiration how the shortening fraction is going, which adds data to the inspiratory effort. But we cannot set aside what happens with inspiration and expiration. Recently, it's been documented that expiratory dysfunction can happen, which is basically regressive recruitment of lungs breathing because of an overload of inspiration muscles. In this case, what we're going to do is evaluate with the linear transducer on the level of the abdominal rectus in the inspiration stage what's going on. Initially, no contraction should happen, but you can see how, as the expiration happens, there is a progressive contraction of the rectus muscles, and we complete the evaluation with ultrasound on the level of rectus abdominis, which, because of the hierarchical order of muscle activation in the inspiration, we have first phase inspiration and then a relaxation. As we can see, the synchrony happens with rectus abdominis, which are activated in the opposite direction as the muscles. Okay, here we have this example of a patient with an excessive load. You can see P sub zero increases in the inspiratory pause. We can see how there's a progressive elevation of the plateau pressure. And when we do the occlusion, we have a value of minus 17, which leads to an excessive effort. Okay, this graph simply summarizes what we've been mentioning, how the neuromechanical coupling of patients occurs. To conclude with this slide, which has been split into 4 quadrants in terms of the possibilities that we can have when we reawaken a patient. Green, safe breathings with P sub 0 between 1.5 and minus 1.5, muscular pressure that goes between 5 and 10, shortening fraction on average 30%, and an assessment scale for respiratory distress below 3. This is a patient that we're going to be able to make progress with successfully. Okay, as for cili and myotrauma, we're going to have a high respiratory drive because of an elevated B sub 0, elevated respiratory effort due to a muscle effort above 3 with intense shortening, and we're going to see asynchrony such as flow set and expiratory distress. And an intermediate point that we see frequently and locally is patients that are over-assisted in a process of reconditioning with a lot of prone and muscle blockage, where we can see a phase of over-assistance and over-sedation with a P sub 0 muscle pressure and low shortening, where we can see asynchronies as an inverse trigger that leads to a neuromechanical discoupling process due to diaphragmatic reconditioning that we will see because of the elevated P sub 0, but low inspiratory efforts, muscle pressure, and shortening pressure, but with signs of dyspnea and discomfort produced by an observation score that is higher than or equal to 3. Okay, this completes the comprehensive approach of the neuromechanical coupling of the patient, determination of safe spontaneous breathings in patients with COVID-19. Thank you. Dr. Carrizosa, thank you so much. Excellent review, very good presentation, very comprehensive. I believe that the very last slide consolidates most of the most frequent conditions that we're facing with our patients. And we hope that in the Q&A, we can clarify some of these. Now, as we continue with the activity, we have Dr. Manuel Alvarez. Manuel is a cardiologist and intensivist, and he is going to do a presentation on vascular damage and coagulation in COVID-19 patients, a key part of the gaseous exchange, trying to visualize and get us out of the gaseous compartment that concerns us so much, and that now we want to generate more awareness about the vascular compartment that has gained so much importance, and we've talked about that all morning. Manuel, thank you so much for being with us. You're next.
Bueno, muy buenas a todos. Muchas
Good morning,
gracias,
everyone.
por la invitación a este
Thank you so much for your invitation to this event. My name is Manuel Álvarez Gaviria. I'm an internist in the Fundación Santa Fe of Bogota, and I'm part of the critical medicine and intensive care medicine. We're going to talk about vascular damage and coagulation in COVID-19 patients. I have no conflict of interest in regards to this talk. My opinion, my views are not influenced by any laboratory or any commercial product. This is the agenda for the talk. We're going to start with a short introduction. We're going to talk about the physiopathology of what are the main hematologic alterations that we're going to find. Then we're going to talk about the coagulopathy itself, and then to talk about some treatment strategies that need to be taken into consideration in this group of patients. This virus that was described at the end of 2018 in China has had a big impact in public health in all of our continents. It has a lot of affinity for the respiratory epithelium coming in through the ACE2 receptor, ACE2 receptor, and then it leads to an activation of alveolar cells type 2 and macrophage, and it leads to a liberation of cytokines that leads to an immunothrombosis. This hyperimmune response is what can lead to a big damage to the epithelium with a deposit of alveolar fibrin and formation of microthrombosis, which can lead to the dysfunction that we're going to have both on a vascular level and that are going to lead to finally in a coagulopathy. When this change is sustained over time, it generates a cytokine storm that is responsible to the high lethality of this virus. The endothelial damage that is presented in COVID-19 is a microcirculatory damage, both in at the level of the lungs and in other vascular events. And it creates this vascular damage at two levels, in a direct way, by leading to an apoptosis, and this leads to a reduction of the anti-thrombotic activity. It also produces vasculitis, which in the end lead to all these micro and macro thrombotic events that we're going to describe. That's why you need to have a close monitoring of the patient to watch for these thrombotic events that will lead to bad outcomes. This explains the presence of cerebrovascular events even in young patients. It also explains the increase in myocardial ischemia that we're going to describe in these patients. And we also find that this microvascular thrombosis can also be related to the multi-organic impairment that can be found in these patients, especially when there is a prolonged infection. From the physiopathologic point of view, the COVID ARDS will have as its main characteristic the diffuse alveolar damage, the increase in the permeability of epithelial and endothelial cells, and some membranes, the hyaline membranes rich in fibrin. And if we add to that the systemic embolism and lung microthrombosis, will mean to the gaseous exchange will be more complex. It won't happen. And then our patients are going to have complications. We should always remember all this cascade of events and the cytokine storm that we're talking about, especially through the activation of the neutrophils of the macrophages and the cytokine storm, which is what explains or what adds up to these Rs that these patients have. Within the mechanisms that have been proposed for the generation of the coagulopathy and the thrombosis in COVID-19, we're going to have some risk factors clearly identified where cardiovascular disease, it plays the most important role. If there is an acute disease, is a risk factor, genetic factors, the presence of fever, of diarrhea, of sepsis. If there is a chronic disease like hepatic lesion or the presence of cancer are also risk factors. Among the inflammatory responses that goes together with the endothelial dysfunction and the superposed infection, it's important to take into account the lymphopenia that these patients have. As far as hemostatic abnormalities, as we were saying, we're going to have more pulmonary microthrombosis. You can have an intravascular coagulopathy, a myocardial lesion, and an elevation of the cardiac biomarkers. And even though you can have this increase in this kind of patients, you need to do a diagnosis, a differentiated diagnosis of this. As in the hemostatic abnormalities, it's important to evaluate the D-dimers, or the D-dimers, and the platelets. And this could also show us in what stage of the disease we are and how compromised is the health of our patients. And as far as the clinical outcomes, we should not rule out the possibility of a venous thromboembolia or an infarctum. Other hematologic alterations that should be considered are the ones that are related to the antithrombin. What we're going to find here is that there is a slight reduction, about 80% of the activity, and this is not related to the prognosis as we were showing on the table. So we have two scenarios. Number one, we can have the coagulopathy related to COVID-19. The other one can be the disseminated, and the other one, the coagulopathy induced by sepsis. These are the parameters that we need to take into consideration to see what kind of coagulopathy we are facing. So we have the number of platelets, the D-dimers, the enlarging of the proton beam time, and if they have more than 5 of these criteria, it will be a disseminated intravascular coagulopathy, and otherwise it will be a sepsis-induced coagulopathy. So in sepsis-induced coagulopathy, we don't take so much into consideration the fibrinogenous nor the D-dimer, and in the disseminated, we don't take into consideration the SOFA score. To end, the coagulopathy, the COVID-19 coagulopathy is similar to the others coagulopathy. We always need to do a quick treatment of the underlying infections. If we don't have a specific antiviral treatment for SARS-CoV-2, we need to do an antimicrobial treatment, especially in the patients that have concomitant infections, especially when there is sepsis and they are critically ill with an acute pulmonary lesion. Another important point is that this COVID-related coagulopathy might not develop a disseminated intravascular coagulopathy or a sepsis-induced coagulopathy, and they might not need hemoderivatives. So we need to follow the recommendations. This is the last guidance that came out in 2013 and is still valid today to lead our treatment of this kind of patients. Another important point among the treatment strategies is the use of, uh, of heparin of low molecular weight. It leads to an increase. It can help those patients that have an increase of the D dimer just by itself. It has a big impact through the heparin of low molecular weight, especially when it's over 6 times over the reference value. So just with this criterion, it's enough. It's to leave doses of anticoagulation to these patients. And the activated C protein has an anticoagulant effect that is very limited and is not recommended for this kind of patient. There is an algorithm that I feel is very useful when assessing how to use antithrombotics in our patients with COVID-associated coagulopathy. The first thing that we need to ask ourselves if the patient has had a previous treatment with anticoagulant. If they have a previous treatment with anticoagulants, we should suspend the oral anticoagulant treatment and add the heparin in therapeutic doses. If they are receiving antiaggregants, we need to see if this is a pathology that still requires the use of an antiaggregant. And if the patient needs a dual therapy, then we can leave the clopidogrel as an antiaggregant plus the anticoagulation with heparin. If the patient comes with a dual therapy, because of the possible interaction with anti-aggregant drugs and some drugs that are in some COVID-19 treatment protocols, maybe we should substitute them, replace them with Trasurel. And then you can also use aspirin, although this doesn't have that much impact on those patients that needs a dual treatment. If the answer to our initial question is no, we need to see if the patient feels some clinical parameters to think about the possibility of administering anticoagulants. Otherwise, we would just give them a prophylactic doses. And if they feel the criteria, we can give them an intermediate doses, providing we take into consideration those criteria. If they present the 3 criteria that we mentioned before, the increase in the dimer tier or the increase in TP or in the platelets, is better to use the heparin at therapeutic doses. And also if they have a venous thromboembolic event, if they only have the dimer D elevated over 6 times over the reference value, it's better to also administer heparin.